All right. I'll go ahead and get share my screen here. All right. So again, thanks for joining. I'm going ahead and kick us off here, the start of season call. In doing so, I want to introduce some of our team members. Maybe there we go. So this is our team. It has definitely grown these past few years, which is great, and we proudly call ourselves the Nerds team, standing for the Nebraska Influenza and Other Respiratory Disease Surveillance Team, which is this tongue twister. So nerd is much shorter and more fun to say. So you'll hear from just about all of us shown on this slide here throughout the presentation, just talking about different aspects of our overall respiratory disease surveillance in Nebraska. So I'm gonna get things started. I'm gonna start with influenza, and then we'll jump into some other, couple other respiratory viruses. But firstly, with flu, as a lot of you probably know, it's a contagious respiratory illness caused by multiple influenza viruses. Primarily, there are two specific flu viruses that cause infections in humans, those being influenza A and influenza B. And why we have such an extensive surveillance system and why influenza is important to track each and every year. To help try to put a number on that, I found this stat from CDC. Since 2010, every calendar years, they estimate around 9 million to 41 million flu illnesses occur each and every year. So the quickly looking at last season, so the 2023-24 surveillance season, both nationally and in Nebraska, influenza A H1N1 was the predominant strain. We did see a little bit, at least here in Nebraska and nationally for that matter, we did see a little bit of influenza A H3N2 as well, and also saw some influenza B in circulation, which was a little bit unique just since the COVID-19 pandemic. There really hadn't been a whole lot of influenza B identified. But last year, it seemed to come back in what we would typically expect to see in like a pre-pandemic influenza season. So nothing too unusual there. One thing, as I've mentioned before, if maybe some of you remember from past calls and past years, we tend to keep an eye on how influenza is um, occurring in the southern hemisphere. So their influenza season is just about wrapping up, if not has already wrapped up. And overall, most countries in the southern hemisphere saw a low to moderate flu season. So nothing too unusual, nothing too really low or overall high. But of course, there's definitely some varying levels of activity when you go country to country. And I listed some of those countries here towards the bottom of the slide. And then also have a link to where I received all this information from CDC to those who maybe want to do a little more digging into it. But overall, in South America and Oceania countries, they primarily saw influenza A H3N2, while in Africa, they actually saw more influenza A H1N1 compared to those other countries. So now we are fastly approaching the new surveillance season for the 2024-25 year. That season will officially begin this upcoming week on September 29th, and that coincides with MMWR Week 40, which you might hear us talk throughout this presentation. That stands for Morbidity and Mortality Weekly Reports. It's a basically a CDC um, way to track weeks. It's assigned as a week number to each week from starting Sunday going through Saturday. So for influenza surveillance, we always start our seasons on week 40, and that tends to fall on the start of October. So just want to provide a little bit of context there. And right now in Nebraska and for much of the country, influenza overall activity does remain low. So next, just wanted to share a few screenshots of a couple figures that CDC puts out on their FluView webpage. The link can be found here at the bottom of the screen. So this is a quick look at some laboratory data. On the left side, we're looking at influenza A and B positive tests overlaid with test positivity reported out by clinical laboratories across the country. And then on the right, it's a little bit of a deeper dive into those positives, looking at specific influenza subtypes. So, like the AH1s, AH3s, influenza B Victoria lineages, etc., that were reported out by public health laboratories. Again, this is last year's data, the 23-24 season on both sides. And as you can see, we kind of saw as a country two little peaks. Nationally, the first peak occurred here around week 52, which would have been the end of December. And then we also saw like a secondary wave around end of February, early March. And like I mentioned a little bit ago, this past season was a little bit different than the previous ones. Since the COVID-19 pandemic, we saw this wave of influenza B towards the second half of the year, which pre-pandemic seasons, this was definitely not uncommon, but it was just the first time we've observed that since COVID-19 pandemic started. And those influenza B positives on this figure are noted in this dark green. And then on the right, we're just looking at this breakdown by subtype. So this orange color here in the middle, those are the influenza AH1N1s, which were predominated for all the subtypes, but we did nationally see a fair amount of AH3, which is here in red, and then these green shades represent influenza B, B Victoria. All right, I'd be remiss if I didn't talk quickly about influenza vaccination, as it is our one of our best prevention tools we have against flu. So it's flu vaccines recommended for everyone above 6 months or older. And those of you who are 65 and older may be recommended for a higher dose. One important thing I wanted to call out with the flu vaccine this year, it is now a trivalent vaccine. It's no longer quadrivalent. So that just means there are three viruses instead of four that are included in the formulations for this year's vaccines. That is because influenza B Yamagata lineages hasn't been detected globally since 2020. So the decision was made to drop it from the vaccine and just stick with influenza AH1 like virus, AH3N2, and then flu B Victoria lineage. So here towards the bottom of the screen, I pulled this from CDC's website looking at the specific viruses that are used in this year's vaccines. And one thing to note that's noted in red, the H3N2 virus was updated in both the egg based vaccine and also the cell or recombinant based influenza vaccine. And just one other thing to point out here, and this was new as of last season, that anyone with an egg allergy can receive the egg-based vaccine. I mentioned that last year. That was a recommendation that came out before last surveillance season, but I just wanted to reinforce that. So anyone with an egg allergy can be giving the egg-based influenza vaccine. All right, let's dive into some Nebraska specific surveillance now. So, our surveillance here in Nebraska really started in 2003 and now has grown quite a bit into seven various surveillance systems that we'll talk about today. And all of these play an important part and an important piece of the puzzle to help us get a grip on what and how influenza is circulating here in our state. So it helps us determine when we might first see a rise in flu activity. We're at in the state, maybe we're seeing more activity compared to other areas. How it progresses throughout the year and into the winter, into the spring, and then what specific strains might be circulating and more so than others. And then that information also is very important for helping determine current vaccine, whether it's protecting against currently circulating strains or not. So our surveillance program overall is definitely not just here at DHHS. It is a huge collaborative effort between some folks here at the state, local health departments, public health and clinical laboratories, vital statistics offices, healthcare providers, clinics, emergency departments, hospitals, and everyone here on this call all make this program possible and what we feel like is a pretty strong surveillance program. So I have outlined here on this slide the seven surveillance systems used for flu that will go it through one by one. My team and I will, our team and I will go through them. So I'm going ahead and start off with talking about laboratory surveillance. So we kind of have a two-pronged approach into getting good influenza laboratory data. Um, so, firstly, on a weekly basis, there is an online survey that goes to 31 laboratories who are not enrolled in electronic laboratory reporting or ELR. So, this is like a weekly aggregate survey that captures a number of influenza and RSV actually positive tests and then also tests performed. And in addition to this, we also have roughly 158 laboratories who are enrolled into electronic laboratory reporting and will get these electronic influenza lab reports, both positives and negatives, daily. And that is reportable per our rules and regs, and I included and specified that in parentheses at the end of that bullet point. And then all other hospitals or clinics that may not fall into either of those two buckets are only required to report if they are experiencing an outbreak. And again, that's per our rules and regulations. So, in addition to this, we have what we call our Sentinel laboratories that are identified each year, and they're asked to help in routinely submitted specimens to our Nebraska Public Health Laboratory, or NPHL, as we'll refer to throughout this recall, and just to do a PCR testing, then also subtyping of the influenza virus. So, how this works is we look at the previous season's influenza testing volume, and per each of our local health department regions across the state, we select the highest volume lab to be a Sentinel provider. So, or excuse me, Sentinel laboratory. And each Sentinel laboratory is provided 10 collection kits. And a little bit new this year is these specimens that get submitted as part of this network will get submitted to MPHL, I should say, will get tested not just for influenza, but we're expanding our respiratory virus testing in Nebraska to try to more routinely test for RSV and SARS-CoV-2 at the MPHL. And then for those that are positive for influenza A or B, they'll either get subtyped out or have a lineage determined depending on the result of the flu test there. And then also a new and exciting thing, we in the MPHL had received some new funding that is going to allow for the top specimen submitters to have a chance to win a $50 gift card each week throughout the surveillance season. And then on top of that, the overall top specimen submitter will have a chance to win a $250 gift card, and that's for our Sentinel laboratories and also our Sentinel providers, which we'll get into a little bit later in this presentation and reinforce that. So, one very important reason why we're making this effort to get specimens to MPHL to be tested specifically for flu is the submitted specimens really aid in helping get a national picture of potential antiviral resistance patterns that may be being seen in these influenza viruses, and also assists with the determination of the following influenza season's vaccine to try to make it as effective as we possibly can. All right, so I just want to go quickly over MPHL's new alert system. So this is MPHL's test ordering system. So when a laboratory, such as the Sentinel laboratories I mentioned before, do submit a specimen, they use this new alert system to do so. So essentially, how this looks is a lab or providers can use this too. We'll begin an order by searching for a patient, or perhaps creating a new patient if this is a person who's not in the new alert system yet. So they'll go through, fill out some ordering provider information, the type of test that's being requested, and then also towards the end answer some epidemiological questions pertaining to the patient being tested. And then once that order is reviewed and complete, the lab will go ahead and or whoever is submitting the specimen will send that along with the printed page of the order to MPHL. And then here at the bottom, if anyone is curious to set up a new alert account or has other questions, you can contact MPHL's client services at the number listed at the bottom, or you can visit their website, which is listed at the bottom as well. All right. And I also wanted to touch base with novel influenza and how laboratory surveillance really can strengthen our surveillance for novel flu. Um, is absolutely crucial for novel influenza detections, as which was recently evident, which I'm sure a lot of you have heard over in Missouri. They recently detected a human case of influenza A H5N1. And this case was actually detected through routine influenza surveillance that they have had established for many seasons now, where the hospital where the patient this case was seen at actually had their influenza positive just routinely submitted to the public health lab for testing, and that's how this was detected. Otherwise, if the hospital didn't submit this specimen just through a routine manner, this case likely would have gone undetected. Excuse me. So, subtype identification for influenza A positives is especially important when testing persons with potentially high risk exposures to potentially detect these novel influenza cases. It just really underlines the importance of obtaining good, thorough exposure histories on patients when influenza subtyping may not be immediately possible. So, like for example, if a patient may present to a clinic with flu-like symptoms and they test influenza A positive, like on a rapid antigen test, for example. If you can obtain a good exposure history to learn maybe if they had an exposure or recently attended an agricultural fair where there could have been sick swine present, that would be really good information to know, and then alert local public health or state public health so we can try to get a specimen sent to MPHL so we can get a subtype identified. Um, so, lastly, I hope this message has maybe gotten through some to your channels previously, but any unsubtypable influenza A positive specimens, so that would be like an influenza A positive that would also be influenza AH1 and AH3 negative. Please contact your local health department or us here at DHHS immediately so we can help coordinate some additional testing to get a subtype identified at MPHL. And really important, the sooner notification occurs, the faster we as in public health can respond and investigate to hopefully reduce the risk of any potential spread of these viruses. All right, finally on laboratory surveillance, and this will be kind of a common theme throughout this presentation as we end an overview of a specific surveillance system, is this to show some data because we love data as EPIs and really want to highlight some of the data that's being captured through all the efforts from a lot of you on this call to show how we're portraying this. So all these data figures are publicly available in our weekly respiratory data report posted on our DHHS seasonal respiratory disease website, which we'll share a link to that later. But this specific figure is looking at last year's data, looking at influenza A positives and influenza B positive tests by reporting week. The flu A positives are these top bars here, the lighter blue color, and then the flu Bs are the bottom blue, and then it's overlaid with this red line looking at test positivity. So if you may remember earlier as a country, when we looked at that overall season nationally we peaked back in late December, and that wasn't necessarily the case for us here in Nebraska. That second wave of activity was much more prominent here, and that's where we actually peaked towards the start in toward the start of March. So, and we did see quite a bit of influenza B2, as you can see when we peaked. We really peaked for influenza A and B at kind of at the same time. All right, so I'm going to move on to school absenteeism surveillance. So this program, on a weekly basis, is data reported directly from schools on the number of absent students due to illness through our school absenteeism red cap survey. So once a school is enrolled into this program, they will receive a new survey every week to complete, and the survey collects a wide array of data and information, including on the number of student absences, the reason for those absences, and if any classrooms or school was closed potentially due to illness. So if you are a school on this call and hearing or learning about this for the first time and you want to enroll your school into this, please contact your local health department so we can kind of get that ball rolling and get you set up with there. All right, so here is a data figure that we put in our weekly report using this data. So this again, this is last season's data, and we're looking at the number of reported student absences by specific reasons for absences. So they're listed there, kind of at the bottom there. It's not just specifically for flu or ILI, which stands for influenza-like illness. We also ask about RSV, COVID 19, other viral respiratory illnesses, and then some other non respiratory um, absences, as in gastrointestinal or mental health. So they tend to kind of follow each other all fairly commonly. So definitely see this other, which is this gray line up top, predominate, but all kind of peak here in the mid February to early March, so a little bit before our laboratory peak, but does closely follow that. And if you see these drops here, these there's are highlighted here. They're just low reporting due to like holiday weeks or weekends, so not a lot of schools in session. All right. Now, with that, I am going to turn it over to Hannah Ball to talk about our outpatient ILI surveillance. So, Hannah, go ahead.
Great, thank you. I'm having a small technical difficulty, so my camera won't be working, but IL ILI-Net is basically a federally funded program that looks at outpatient influenza-like illness in all 50 states and many U.S. territories, so Nebraska would be included. It relies on a network of volunteer providers, and how it works is that weekly providers will report both the number of patients that they see that meet the definition on the slide of ILI and the total number of patients that they see. And then also towards the beginning of the season, we do ask for a estimate of population served. Next slide. And then perhaps one of the more important aspects of the program is the submission of specimens. So this year we ask that each provider submit 10 specimens. We do have updated incentives for those. And then the goal of the program is really to get every provider to submit data at least 85% of the weeks, and then to submit up 10 specimens. And in terms of the local health departments, we would like each local health department or local health jurisdiction to have 2 providers. Next slide, please. And then this is just a graph showing last year the peak of ILNet visits was beginning of March. Next slide, please.
All right. Thanks, Hannah. So I'll go ahead and continue with moving on to a new surveillance system. So to talk a little about syndromic surveillance. So syndromic surveillance, if you aren't familiar with, is essentially the real-time or near real-time collection of patient visit data from clinics, emergency departments, hospitals, and other healthcare facilities. So currently, we utilize syndromic surveillance to submit emergency department or ED ILI data for 69 EDs across the state. So we do this by analyzing the discharge diagnoses and chief complaint data for influenza-like illness visits to help determine the burden of these influenza-like illnesses in these emergency departments. So we track these total ILI visits by age group also, and then look at the percent of these ILI visits among all ED visits to get an idea of overall burden compared to all visits being seen at EDs. And this data is aggregated by reporting week. So in addition to the 69 ED facilities, we also use this syndromic data to look at ILI outpatient data from 10 federally qualified health centers and look at the exact same data mentioned above about breaking it down by age group and then that percent of ILI visits. And then we do report this data weekly to CDC's ILI Net ILI-Net surveillance system year-round, and CDC does publish this ILI-Net data on their FluView interactive report, so it can be viewed there on a national level. So here are a couple data figures using our syndromic surveillance. So the top is looking at these ED ILI visits by age group, and then the bottom is looking at that percentage for the past percentage of ILI visits among all ED visits for the past several surveillance seasons. So at the top, looking at age groups, we see them all fairly represented, but definitely there's more of a skew to the younger age groups. So that would be there in blue at the top, the 0 to 4-year age group, and then in orange, which is that second bar here, being the 5 to 24-year age group. And again, like some of the figures we've seen so far, this surveillance data has also shown a peak around the start of March. And then historically, looking at this in red represents last year, so that's the 23-24 season, and then the prior 3 seasons are also represented here in gold, the 22-23 surveillance season, and this light blue is the 21-22, and then this darker blue here, kind of at the bottom, is more of a flat line, is the 2020-21 season. So compared to the previous year, the 2023-24 season peaked a little bit later than the 22-23. Again, roughly lining the late February to early March when we saw a peak activity. All right, and I'm gonna pass the mic on back to Hannah to talk about outbreak reporting.
So this is a picture of our regulations regarding outbreak reporting. And as we can see, for COVID right now, the current definition of an outbreak is 1 case. However, that might change, and if that changes, we will let the appropriate entities know. For non-COVID, it's 2 or more cases within 72 hours of each other, either 2 positive cases or 1 positive case with additional symptomatic persons that are clinically compatible. Next slide. And then when we have an outbreak for most jurisdictions, we will let the local health department or local health jurisdiction know. And then we will also send the link to the outbreak survey, and then they will send it on to the facility. Next slide. And then this is just explaining the different parts of the outbreak survey. We have a summary form, we have a healthcare facilities form, and we have a patient line list. The patient line list is optional, but we would like it if possible. Next slide.
All right, thanks, Hannah. So we wanted to quickly mention the ICAP program. So that is the Infection Control Assessment and Promotion Program. So this program is supported by the Nebraska DHHS HAI/AR program, and is a team consistent of experienced infection preventionists, infectious disease trained medical directors, and professional educators. So they are a great resource and offer no cost peer-to-peer infection control assessments to all facilities here in Nebraska. So out here we bolded some specific areas where they can be of use to folks here on this call. So they will help with conducting infection control assessments and recommendations. They will collect and analyze the data from us here in EPI, and then they have a plethora of resources that can be given to facilities to help fill infection control gaps, and also provide resources and help if any facility may be experiencing an outbreak. So if you have or want to know any more about ICAP, we threw their link to their website here that can be accessed. Okay, moving on to our hospital ILI emission surveillance. So this is a weekly survey where 87 hospitals submit influenza-like illness, again, that stands for ILI, admissions data. So The facility can either directly submit this data via the survey themselves, or they can have their local health department assist them in getting this data reported to the survey. So the current case definition for ILI is the same as it is for those other surveillance systems, such as the syndromic surveillance. It is someone clinically diagnosed with influenza or having a fever above 100 degrees Fahrenheit and a cough and or sore throat. So if you are anyone interested in receiving this data automatically instead of manually counting, you can reach out and we can help potentially support that. All right, now looking at some data captured by this survey. So here we are looking at the total number of ILI admissions by week for the past few seasons. So these colors here shown reflect the previous figure I showed for the syndromic surveillance. So again, the past season of 23-24 shown in red with the subsequent or the past prior 3 seasons. So last year, again, we didn't see, compared to like laboratory surveillance, let's say, a really large peak. Not saying that this is an insignificant number of ILI admissions, but we saw the peak around late February, early March. Again, that's coinciding pretty closely with these other surveillance data. And compared to previous seasons, a little bit later than what we have seen prior, which sort of makes sense when we know that we peaked with lab positives around that time of year. All right, I'm going to introduce and pass it off to Quabilla Montgomery, and she is going to talk about mortality surveillance. So Quabilla, go ahead.
Good morning. So Nebraska utilizes the Electronic Death Registration System, EDRS, for surveillance of our influenza-related and RSV-related deaths. We search for ICD-10 codes and causes of death, underlying or immediate for influenza and RSV. In the same vein, it's very important to put influenza as an underlying cause, if applicable, because it makes it easier for us to use surveillance. Sorry, give me 1 second. I'm gonna put on my camera, that way everyone can see my face. There you go. It is required to report all influenza-associated pediatric deaths to Public Health Authority. Adults are not reportable for RSV or influenza, but you can still report it. That way we do have better numbers on the mortality. On our DHHS website, we submit weekly flu-reported information that displays seasonal death totals for influenza and RSV respectively, and we specify pediatric deaths in this report if there are any for the season.
All right. Thanks, Quabilla. So that is a wrap for influenza. Going to transition to talk about RSV a little bit. So here, CDC defines RSV as a common respiratory virus that usually causes mild cold-like symptoms, those listed there below. But in very young infants, it may present a little bit differently as only appearing as irritability, decreased activity, or potentially difficulty breathing. So transmission is pretty well just like a lot of respiratory viruses, mainly via respiratory droplets. Thermite transmission can occur with RSV. Most people tend to recover in 1 to 2 weeks, but RSV can definitely be serious, especially in infants and older adults. And in fact, for children younger than 1 year of age in the United States, RSV is the most common cause of bronchiolitis and pneumonia. So as far as care and treatment goes, there is no specific treatment available for RSV like there is for influenza, for example, or COVID-19, where they have specific antivirals. That is not the case for RSV. So RSV is typically managed through managing symptoms. So managing the fever or pain with over-the-counter meds, pushing fluids, and then definitely recommended to contact your healthcare provider as needed as your illness potentially progresses. So even though we don't have any specific treatments, we do have quite a few very effective prevention options. So firstly, some prevention methods that are just routinely recommended for all respiratory viruses, right? So like influenza, COVID-19, effective for RSV as well. So that is covering your coughs and sneezes, ideally into a tissue, your shirt sleeve, hopefully not into your hands. Practicing proper hand washing with soap and warm water, trying to avoid close contacts, especially those who may be at risk of severe illness. Cleaning and disinfecting frequently touched surfaces, perhaps like at a daycare, for example. Then also, if possible, stay home while sick and try to avoid others as best possible if you are sick. So there are two prescription monoclonal antibody therapies specifically for RSV that help prevent severe RSV illnesses in infants and children. I want to really emphasize that this drug helps prevent serious illness and it cannot help cure or treat children who are already infected with RSV. So these two therapies are listed here below, and I'm going to do my best not to butcher these names, but the first one is nirsevimab. So this was a little bit newer. It first was approved and available at the start of last season. So this is just one dose that is to be given before RSV season, or if there's an infant born during the season, ideally within 1 week of birth, if possible. And the season's tentatively defined as running through October to March. So really resembles the flu season, quite honestly. So the recommendation to receive this is any baby younger than 8 months of age born to mothers who didn't receive the maternal RSV vaccine. But it can also be given to young children aged 8 to 19 months who may be at an increased risk for having severe RSV illness. Now, the second monoclonal antibody therapy has been available for a little while. I'm not sure when it first became available off the top of my head, but this is Synagis. It's given as a monthly dose throughout RSV season, so roughly 5 months, so 5 doses. And this is recommended just for infants or young children under 24 months of age who are at an increased risk of severe RSV illness based on both gestational age, and I'm pretty sure I said that wrong, sorry, and underlying medical conditions. All right. And secondly, to continue the RSV prevention talk is RSV vaccination. So this too is recent, somewhat recently new. Last year is the first year these RSV vaccines were made available. So there is a slight change for this year in terms of the adult recommendation. So it is routinely recommended in adults this year for anyone age 75 or older, and that can be seen in this first row here on this figure from CDC, but also adults who are age 60 to 74 who may be at increased risk of severe RSV are also eligible. And then the second row in this chart here, this goes a little more in depth about nirsevimab specifically. That's that monoclonal therapy that we just talked about. And then at the bottom, it gives the recommendations for receiving RSV vaccine to mothers during pregnancy. So it's recommended for all pregnant persons during weeks 32 to 36 of their pregnancy. All right, so to wrap RSV up, we'll show a little bit of data. So the surveillance systems for RSV really overlap with flu. So for most of the ones that we've talked about, specifically laboratory syndromic data, where we not only look at emergency department data, but we actually look at inpatient facility data in syndromic for RSV, and then also, of course, outbreaks and mortality. So the two figures here in the top right, this green figure is looking at the lab positives for RSV by week overlaid with positivity. So in the bottom left is our syndromic emergency department visit, RSV visit data by age group. So as you can see in both of them, we peaked roughly mid to late December, so a few months before we peaked with flu. And as evident in the bottom left graph, very much affects the 0 to 4 age group the most when looking at those ED visits. All right, I'm going to quit talking for a little bit and pass it on to Sai Paratala to talk about COVID-19. So, Sai, go
Thanks.
ahead.
Thanks, Derek. Good morning, everybody. My name is Sai Pardala. For those who don't know me, I'm the COVID-19 epidemiologist here. Interest of time, I'm going to be brief through the slides, but please feel free to email or in the chat box as well for any if you have any questions. Let's start with a look at COVID-19 levels in Nebraska and US. I posted 3 links. You can refer to that to look at the wastewater levels across most states. We are seeing high or very high levels of COVID-19 in wastewater, signaling continued biocirculation. However, in Nebraska, the situation appears more stable. We've seen a slight uptick in reported cases, mainly concentrated in urban areas, but it's important to note that most of these cases have been mild to moderate. Regionally, there is variability. If you look at those links, the West seems to have peaked, the West Coast, while other regions are still experiencing rising COVID levels. This suggests that parts of the country are at different points in this current wave. When looking at current indicators like ED visits, test positivity rates, we see signs that wave might be cresting, and these metrics have peaked. I would say this is encouraging, but we must stay vigilant. Unfortunately, hospitalizations are continuing to rise across the country, and for the third consecutive week, there have been 1,000 deaths reported due to COVID-19. But on a positive note for Nebraska, hospitalizations have remained steady and low, and there's no significant rise in severe outcomes. While this is reassuring, I think it's essential we remain, we continue our surveillance efforts. Next slide, please. Next slide. No problem. Thanks, Eric. I'm sorry the picture is a bit blurry, but if you go to the item 3 in the chat that I posted, I want you to focus on this COVID-19 forecasting for the upcoming respiratory season. The Center for Forecasting and Outbreak Analytics, they did an excellent job. Their models are robust and the methodology is robust. This scenario modeling captures various elements. This includes age-specific hospital admissions, seroprevalence, and variant proportions. It also considers expert view to account for key uncertainties like vaccine uptake and effectiveness, and as well as potential for COVID-19 variants. The key takeaway, there are a lot of figures, but this figure, the key takeaway for COVID-19 this season is that peak hospitalizations are expected to be similar to or even lower than last season. However, there are uncertainties that some uncertainties remain, particularly around how summer wave could impact the dynamics of the virus as we head into the colder months coming fall. Emergence of new variants or reduced vaccine effectiveness still could cause higher burdens, but based on our current data, the overall look suggests a manageable situation for our healthcare systems. This, of course, will depend on continued surveillance efforts and vaccination efforts. Next slide, please. Let's move on to what's latest on COVID-19 and what we can expect this respiratory season. This summer, we saw an unexpectedly large surge in COVID infections across the US with the fall and winter virus season right around the corner. It's important to stay prepared. The dominant variants that are circulating right now are KP1, KP2, and KP3, and all of their sublineages, all of which have shown slightly higher transmissibility and partial immune escape. These factors actually contributed to the summer surge, but it's important to know that hospitalizations and deaths kind of remain lower compared to previous surges. So in response to these variants, updated vaccines have arrived. FDA approved new mRNA vaccines in August 2024, targeting the current KP2 variant, which has been the major driver of infections. These vaccines are from Moderna and Pfizer. They're available for everyone aged 6 months and older, and they offer strong protection against severe illness and hospitalization, even with the immune escape features of the current variants. And this is backed by robust data. Additionally, for people who want to choose protein-based, there's Novavax protein-based vaccine that targets the JN1 variant, which is prevalent early in 2024. Both type of vaccines are being shown in lab experiments to recognize the circulating variants. For those who haven't received a COVID vaccine in the past few months, CDC recommends to get vaccinated or getting vaccinated as soon as possible, especially if you're at higher risk of severe illness. And lastly, and also it's worth noting, sorry, these vaccines provide protection against infection for up to 3 months and against the severe disease for up to 6 months with these emerging variants. It's important to remember that COVID vaccines still remain as one of the best tools we have to protect against severe illness, hospitalizations, and death. While infections may still occur, vaccinated individuals are far more likely to experience mild symptoms compared to those who are unvaccinated or haven't received updated vaccine within the past year. Next slide, please. So these are our Nebraska COVID-19 metrics over the past 90 days. In last 7 days, 668 cases were reported by lab report date, which marks a slight decline with average number of cases being at 95.4 per day. This represents a 4.4 decrease from previous period. Similarly, the data by specimen collection date also shows 688 cases with average of 98.3 cases per day, down by 4.7%. The rolling average helps illustrate the overall trend, which the red one, which shows a clear peak in mid-August, followed by a steady decline as we approach the end of September. A majority of the tests were PCR, accounting for 68.4% of the cases. These trends reflect what we observed nationwide, summer surge caused by more transmissible variants like KP2, as we discussed, but we are still seeing cases, particularly in urban areas. So encouragingly, dip in cases suggests the surge is losing its momentum, relative mild to moderate cases dominating the current landscape. But as we move into this respiratory season, it's critical to continue monitoring these trends. Next slide, please. Thank you. Let's look at these COVID-19 trends across LHDs in Nebraska. This chart highlights the weekly trends for COVID-19 cases, percent positivity, and weekly COVID-19 rates across different LHDs. We can see a variation in the case rates across state. For example, Douglas and Sarpicas show some of the highest weekly case rates peaking around late August with a rate of over 50 cases per 100,000 in Douglas and as high as 86 cases per 100,000 in Sarpicas. By early September, Douglas still maintains relatively high numbers, while Sarpicas has started to show a decline. Counties such as Lou Basin and North Central have maintained lower case rates throughout the period, consistently below 10 cases per 100,000. Probably, my hypothesis is like there's rural-urban divide in the state's pandemic trends. One notable pattern I want to bring your focus is the rise in case and test positivity rates around mid-August. It coincides again with the national summer surge. Overall, the variability reflects regional differences and also the ongoing impacts of these surveillance efforts. Next slide, please. And this one is again a more detailed trend where we can see Douglas County showing a consistent increase in case rates, sitting at around 5 cases per 100,000 population. This aligns with high case counts we've been seeing in the urban areas. Lincoln Lancaster has experienced a moderate rise in case rates, peaking around late August. It's stabilizing around 6 cases per 100,000. Sarpicas here has a more dramatic increase, so the summer peaking at over 8 cases per day per 100,000. On the lower end, areas like Lou Basin, North Central have maintained lower case rates. But as we move again into the respiratory season, it's important for each LHD to monitor the trends closely and continue coordinating with us to prepare for any potential increases. Next slide, please. So COVID-19 syndromic surveillance, as part of our comprehensive surveillance efforts, this tool highlights syndromic surveillance, which specifically monitors COVID-like illness in ED visits across the state. So syndromic surveillance, as you all know, allows us to track early signs of illness and spot trends, what might be differences in COVID-19 case numbers. So we monitor these visits by different age groups shown in this graph, which break down CLI ED visits. Each color in the stacked bar graph represent a different age group. Orange from children under 5 years to adults over 65 years in green. So this age segmentation is crucial because it helps us identify looking at trends. You can see there was a peak earlier this year, which also coincides with the COVID-19 activity. Next slide, please. So outbreak reporting, ICAP will continue to assist in outbreak situations as they've done so in the past. So if you suspect if your facility has outbreak, please contact your LHD with our ICAP team with the link below. Next slide, please. Good news is first, Unified Hospital Data Surveillance System will resume COVID-19 hospital reporting in November 2024. This system provides a comprehensive overview of hospitalizations, not only in Nebraska, but in other regions. One of the key improvements that they have this year is enhanced data collection. It'll allow us to track more detailed data on hospital capacity, patient outcomes, aggregate patient outcomes. So this level of detail will be important as we anticipate surges during the winter months. The importance of UHDS's data cannot be overstated. With these updates, we expect to respond more to these surges, or the data especially will empower us agencies to make well-informed decisions. Lastly, the system will rely heavily on collaboration with local health departments. Local partners will play a crucial role in using this data, to address unique regional challenges. Next slide, please. Hospitals in data from November 2024 can report the data individually or through a third-party provider, depending on what works best for them. Most common is web interface, where hospitals input the data directly. Alternatively, they can upload CSV files, which is for bulk submissions. Finally, hospitals can use the NHSN API, which also allows automated data submission for even faster reporting. Currently, around 140 hospitals should be reporting from November and report the data to NHSN on a regular basis. This data then will be pulled and analyzed weekly by a team at DHHS. Some of the important insights we gained from this data is number of COVID-19 patients in hospitals and ICUs. It also allows us to identify hospitals, again, under significant stress. It also helps to inform decisions about hospital capacity, make decisions on hospital capacity and staffing. That's what we get from this data. Next slide, please. So just want to show you the COVID-19 hospitalizations in Nebraska. We've recorded 35,669 hospitalizations since the start of pandemic. The peaks we see on the chart present major surges, most notably during the winter waves of 2020 and 2021, followed by a sharp increase in the Omicron surge in late 2021 to early 2022. The color coding here, even though it's blurry, the blue section represents individuals aged 70 plus, which consistently make up the largest proportion of hospital admissions. Orange represents 50 to 69 age groups, which also contributes significantly. Green and yellow, teal represent younger age groups, which show fewer hospitalizations. Moving forward, it's critical to monitor these numbers as we enter the respiratory season, particularly for 70 and 50 to 69 age groups. Next slide, please. From this slide, we see that currently, as of yesterday, actually, 52 active hospitalizations across the state. We have 8 ICU beds that are being used, which represents 50% occupancy, while no ventilators have currently in use. On the left side of the chart, we can see the trend of active confirmed hospitalizations over past 60 days. The red line tracks the proportion of ICU beds in use, which has remained below 50% consistently, reflecting the fact that severe cases requiring ICU have been limited. On the right, we see historical data for overall hospitalizations. It shows a 7-day rolling average. You can see those unusual peaks because the data reporting, the denominators are not consistent in the data that's reported. So it's encouraged. This is encouraging that it indicates like COVID-19 is still in Nebraska. It's still manageable. We are preparing for our respiratory season, and this helps us guide our decision making as well. Next slide, please. Vaccines administered to Nebraska residents are reported by healthcare providers through NESIS, Nebraska State Immunization Information System. Most commonly, they use a web interface, which is most common, secure file transfer connections for bulk data uploads, or direct electronic interfaces that enable seamless data. The data collected through NESIS is essential because it helps us track vaccination rates across Nebraska, and analyze vaccine coverage and analyze vaccine effectiveness. Next slide, please. Thanks. The National Academy of Science put a new definition for COVID, refers to persistent or relapsing symptoms that last beyond 3 months after the acute phase of a COVID-19 infection with no alternative diagnosis to explain the symptoms. Key symptoms are fatigue, cognitive impairment, brain fog, which is respiratory and cardiac issues, and general weakness or feelings of being unwell. One of the complexities of long COVID is these symptoms can fluctuate, making management, treatment, and surveillance a long-term challenge. In terms of prevalence, it's estimated around 10 to 30% of COVID-19 survivors are long COVID. The healthcare response to long COVID has been focused on developing long care strategies and surveillance systems. Next slide, please. So we are optimizing on working a REDCap case report form. This involves revising the form to align with latest COVID-19 guidelines to ensure that we capture all essential data points that's required. In terms of healthcare provider engagement, we are increasing outreach efforts with primary care providers and all levels to ensure that we are capturing accurate data from wide range of settings. We're also focusing on onboarding facilities, those with high volumes of long COVID patients. Lastly, we're also looking into comprehensive training program for participating healthcare entities. That's training is designed to ensure accurate and timely data submission. Next slide, please. And our first milestone is a form update. We are working to update and test a REDCap form to ensure it's both user-friendly and comprehensive. And next is outreach and partnerships, focus on engaging more clinicians and healthcare facilities, and onboard data integration to onboard high prevalence sites, as I discussed, and also focus on training and supporting. Finally, under data analysis and adjustment, we want to regularly review the data to assess impacts of long COVID. This will allow us to adjust public strategies as needed, ensuring that our interventions are effective. And thanks for everybody. That's all for COVID.
Great, thanks, Sai.
Thanks.
So I know we're approaching the top of the hour, but we're just about wrapped up, and I'm going to close with just talking about a couple data deliverables that we do. So as referenced throughout this call, we do a weekly surveillance data report that contains a lot of this surveillance data, and it can be accessed on our DHHS seasonal respiratory disease website, which is hyperlinked there. Two new things to the report this year that we wanted to share is firstly that SARS-CoV-2 data will be added, and essentially the data that will be shown will mirror what's shown for flu and RSV. That sub-bullet there below specifies what specific surveillance data that will be including there. Secondly, we are expanding our other respiratory pathogen section to include Mycoplasma pneumoniae and Chlamydia pneumoniae data. Those are two pathogens that are commonly tested on respiratory pathogen panels. So we get some of that data through our ELR feed. So we wanted to share that as well to go alongside with some of those other respiratory pathogens, such as para-influenza viruses or seasonal coronaviruses, for example. And then if you would wish to subscribe to the report, you can click on that link right there. So then every time we update this report weekly, typically on Fridays, you'll get email notification that it was updated and a direct link to it. And finally, wanted to, we'll quickly go over just a little bit of dashboard talk. So this is a screen snip of our current respiratory illness dashboard. This has been like this version for a few years now, showing RSV, influenza, and COVID-19 data. The link to that is below. But we are very excited and happy to announce that we will have a new and improved respiratory illness dashboard set to go live here in October of 2024. So just a couple weeks. So this dashboard will still include influenza, RSV, and COVID-19 data, but it will have much more data to include. It'll basically be a reflection of what we have historically reported in our weekly data report, that PDF report, just morphed in reimage into a dashboard format. So I took a screen snip of the landing page for when a user accesses the data. They'll be sent to the Influenza tab specifically, and then the layout for Influenza, RSV, and COVID-19 will be very similar. So it helps a user with navigation, hopefully, and then comparing different data from these other viruses a little more directly. And then we created this summary tab for each flu, RSV, and COVID because we understand the average person may not have time to extensively go through the dashboard. So the purpose of this summary tab is to give one data point for the most recent week, and then also the previous week to give a little idea of trend and as well as the season total. And then there is roughly one, maybe two data points per surveillance system included in this summary. Okay, I'm gonna just skip over these two. These are just some additional views that can be accessed through the dashboard. This is looking at some laboratory data, which definitely has the most extensive data figures and tables. And then this is a ILI hospital admissions data, which is going to be shown on the dashboard too. So here's some resources that you all can access. Again, these slides will be sent out in the meeting minutes, and it's recorded as well, and we'll post a recording from today's call on our DHHS seasonal respiratory disease webpage. So you can feel free to share with any colleagues or folks who may have not been able to join this morning. Here is all of our contact information, which I know is a lot, but again, at any point in time, either later today or weeks or months from now, if you have any questions on anything respiratory disease surveillance related, feel free to contact any of us, and we're more than happy to help. So I know we're over time. I tried to keep up with the chat a little bit, but if there's any questions, we can stay here for another minute or two to answer those live, or you can reach out to any one of us directly too. So I'll go ahead and pause. Thanks. All right, hearing no questions now, just want to say thanks everyone for joining today. I really appreciate all of your efforts in helping make our overall comprehensive surveillance possible. So thanks, enjoy the rest of your Tuesday, and take care. Bye, everybody.